Uh, Hello, everyone. I'd like to welcome you all for another episode of FCPI podcast series. You all have been listening to various topics relating to clinical pharmacy practices. In today's episode, we delve into latest trends, challenges, and innovations in healthcare and clinical pharmacy practice. Today, we are discussing a topic of global importance that is on fostering antimicrobial stewardship in public and community settings. I'd like to invite the guest of today's episode, Dr. Vijay Yeldandi, infectious disease specialist. Thank you so much, sir, for accepting our invite from your busy schedule and giving us your time.
Pleasure.
Uh, Pleasure meeting you, sir, always. Before we start the episode, I would like to quickly introduce the speaker for today's episode. Dr. Vijay Yeldandi is interested in immune system disorders and inflammatory disorders. For over 3 decades, he has been managing patients who have autoimmune disorders and have undergone transplantation specialization, as well as patients with HIV infection and other infection related to travel. He brings rich experience in the appropriate use of state-of-art technology with the empowerment of people to take control of their health by embracing salutogenesis, which is the formation of health. His current work encompasses participatory action, research to promote One Health and One Planet, and registry for mycobacterial infections at Suvarna Swasti Research Center. Sir is a clinician, an educator, a public health soldier. He is board certified in infectious diseases. He has received awards in USA for teaching, public health, and leadership in healthcare. He is a member of the Technical Research Group for National AIDS Control Organization, Ministry of Health and Family Welfare, Government of India. His work in India has been funded by the United States Centers for Disease Control and Prevention from 2005 to present to 2025. He is an expert member of Telangana State Action Plan Committee for Antimicrobial Resistance, a member of the Community of Practice for Implementing Public Policy at Harvard Kennedy School of Government. Sir had been rewarded with several awards, and Sir has many publications on his name. Without any delay, sir, let's start today's podcast session, sir. So to begin with today's podcast session, I would want to you to explain briefly about antimicrobial stewardship and why is it essential, especially in public and community settings, sir.
So I think the key thing to understand is infectious diseases are deadly. They can kill people. And what is clear from the evidence published, and there are multiple studies that show this, that the faster you have an effective antimicrobial treatment, the better the outcomes. Let's underline the word effective, okay? Because if that antimicrobial to fight an infection is delayed by several hours, then there is poor outcome, including mortality. The people die. That's the bottom line. I mean, if you don't have access to the right antimicrobial in the right time frame, then the patient does not recover from the infection, and very often that outcome is really, really bad. Now, the problem with using any antimicrobial that you can lay your hands on is it doesn't work. We do not have a magic bullet that will kill every pathogen. So it all depends on us knowing what kind of pathogen is responsible for the infection. And therefore, we can target our antimicrobials towards that specific infection. And our diagnostic technology takes time. Even with the advancements of technology and all of the nucleic acid amplification techniques that we are using that have substantially shortened the duration of time required to make a very specific diagnosis of the pathogen causing infection, it still is too long. Okay, that's not the luxury waiting down. We've got to intervene with an antimicrobial immediately. right? So what we end up doing is we sort of make a guess about what kinds of pathogens may be involved, and therefore that dictates what kind of broad spectrum antimicrobial I choose initially, until I have specific identification of the pathogen. And hopefully I also have susceptibility of that pathogen to the antimicrobials that are available.
Yes.
So that's the ideal situation. You have a patient, you have diagnosed an infection, you have identified the pathogen, you have access to an antimicrobial that is likely to work against that pathogen, and we are all looking at a good outcome for the patient. The patient's life is saved. All right. Unfortunately, what's happening today is a lot of people are getting infected with pathogens for which we do not necessarily have a good antimicrobial available. And we try to overcome that problem by using the broad agents or the latest gulamycin, and it still doesn't work. And the reason it doesn't work is that the pathogen that is causing the infection is resistant to the antimicrobial that is available to me and to my patient.
Yes, absolutely.
If that is a scenario, then obviously you're not doing the patient any good. Okay.
Yes.
The question is, how do you get antimicrobial resistance? Remember that we are not dealing with one solitary organism when we are talking about an infection. We're talking about an entire population of pathogens that is causing the infection. And our strategy should be to annihilate that entire population. So we use an antimicrobial to do that, and that in concert with the body's own immune system is able to eradicate that pathogen population. Now, in every pathogen population, what we find is that there is an entire spectrum of organisms. Some are susceptible, but some are not susceptible. And typically, what happens is when we use an antimicrobial on that population, the susceptible ones all die, but the population, and that may be actually a minority of the initial population, a subpopulation of non-susceptible pathogens, will now replace the susceptible pathogens, and that population expands very rapidly and continues the damage to the human host caused by that bacterial population or viral population or fungal population or even a parasitic population. It doesn't really matter which pathogen it is. They all have the same fundamental property that a minority can replace a susceptible majority. A resistant minority can replace a susceptible majority and negate any beneficial effect of antimicrobials. The problem that we are facing over the several years now, and let me say that in the early part of my career, okay, I did not encounter so many pathogens that were multi-drug resistant,
Yes.
even in hospitals, and almost never from the community. So what's happened over the last 4 decades, all right, of my career, what happened for just my own career. What I'm seeing is that most of the hospital-associated infections are caused by pathogens that are resistant to the antimicrobials that we have available. And in addition to that, to compound this problem, we are beginning to see patients coming in from the community, and they harbor drug-resistant pathogens. And by the time they come in, they're already quite sick. And despite the fact that I know that potentially they may have a drug-resistant pathogen, and therefore I try to use a very broad spectrum agent and a newer agent that potentially is quote unquote active against drug-resistant pathogens, we don't necessarily always succeed and we fail. And then that has a tragic outcome, particularly when it's a bloodstream infection. So this is why what we have now faced with the situation that we have fewer and fewer options available to us to manage this drug-resistant infections in people. So what do we do about it? Well, we first started looking at this problem inside hospitals several decades ago. And I will tell you my own experience with lung transplant patients. Okay. Most of these patients were cystic fibrosis patients, and their lungs were often infected with Pseudomonas aeruginosa that was resistant to all of the agents that we had available. All right. So what do I do? Now, during a lung transplant, almost inevitably, all of these organisms escape from the lungs, get into the bloodstream, the patient goes into septic shock and dies. And that was actually our first experience with a patient who had a very resistant Serratia marchescens, and that patient went into septic shock and died. Okay. So since then, I've introduced routine antibacterial prophylaxis for every lung transplant patient at Loyola University Medical Center. And we were able to succeed in pulling through the surgery lung transplant patients. But what do you do with a cystic fibrosis patient who is now harboring all of these drug-resistant pathogens? I no longer have in my hands a antimicrobial that I can use perioperatively to pull these patients through.
Yes.
So what do I do? So what I did is I took my patients off all antimicrobials. I told them that if you need to be transplanted, I need to make sure that you no longer harbor this very drug-resistant Pseudomonas aeruginosa in your lungs. And lo and behold, what happened is over a period of several weeks, when there was no antimicrobials being used, okay, no antibiotic pressure, they recolonized with drug-susceptible Pseudomonas. And therefore, I was able to use ceftazidime perioperatively and pull them through lung transplant. Now, this experience has been repeatedly seen in multiple different circumstances, all well published, where we have shown that when we reduce the amount of antimicrobials being used, for example, when the quinolone usage is reduced, we simultaneously see a reduction of MRSA infections. We simultaneously see a reduction of Clostridioides difficile infections. We see a reduction of other drug-resistant pathogens. So clearly, reducing exposure allows people to repopulate their own microbiome with susceptible organisms. And therefore, when they do get into trouble, we have a reasonable armamentarium that we can use to tide them over that particular infection. All right.
Yes.
So clearly, one strategy here is to become very, very careful about which person we give antimicrobials. Okay. If we can avoid it, we avoid it. If we can use a very narrow spectrum agent that is unlikely to encourage the emergence of broadly multi-drug resistant pathogens, then that is the preferred strategy. If there are agents that are less likely to have the emergence of resistance, then we preferentially use those agents. Okay.
Yes.
All in all, what it is clear is that reduction of exposure to a lot of different antimicrobials would allow us to have patients or people harbor less multi-drug resistant organisms within their own microbiome and therefore easier for us to treat. Now,
Yes.
how this works in the community is that we have to persuade our people in the community not to keep swallowing antimicrobials every day. Now, look, people are not stupid. There's no reason for them to keep on swallowing antimicrobials every day, okay, unless they have a real problem.
Yes.
But the tragedy is that despite the fact that they have no desire to swallow antimicrobials, despite the fact that they have no infection and therefore no reason to swallow antimicrobials, they are still unwittingly swallowing antimicrobials because those have become incorporated into the food chain.
Yes, yes.
Because of the massive use of antimicrobials in our
Yes.
food industry.
Yes.
So let's take antifungals, for example, which are routinely used. A lot of azoles are routinely used to kill fungi in agriculture to prevent fungal infections of plants that are important for food production. However, that rampant use of azoles has now led to an epidemic of azole-resistant fungal infections.
Yes.
Now, let's take poultry, for example. All of poultry have quinolones added to their feed because that improves the weight gain of the birds and therefore it's commercially more valuable.
Yes.
But eating that kind of chicken is exposing us to a lot of small amount of quinolones that change our own microbiome into a much more drug-resistant microbiome. Same is true of the industry that produces fish and prawns because they use a lot of colistin. So now in the community, people are not aware of this fact. And also, it's not very easy for them to go searching for food sources that have never been exposed to all of these industrial antimicrobial usage or pesticide usage in food production. Because if
These
we
days it
did
is
not
becoming.
use that, then it would become very expensive. The yield would fall drastically. And in fact, you've got to ask yourself, is it wise to, put in a blanket prohibition on the use of all of these pesticides, et cetera, et cetera? Because then what you would see is a drastic drop in food production.
Input, yes.
And a lot more people would have to pay a lot more for their food, and maybe some of the people would not be able to afford food and go hungry.
Yes,
right?
definitely.
So there are no simple strategies that address this problem. So one of the things that I warn everybody against is this is a complex adaptive system. Do not try to apply band-aids or simple reductionist thinking to strategies to address this problem in the community. It's very complicated. And we have to work very hard to try and see where we can make suitable adjustments. The other problem that I have is this notion that you have to completely restrict use of antimicrobials without a quote unquote doctor's prescription everywhere. Now, that on the face of it, that sounds very logical because that would reduce the exposure to antimicrobials where it is not strictly necessary because it is being controlled by a physician who ought to know when to use antimicrobials and when not to use antimicrobials.
Yes.
However, we need to remind ourselves that 60 to 70% of our population has no access to doctors because they reside in rural areas where there aren't many doctors that you can find, right? And look at a child who has high fever, a young infant, high fever. By the time a person, a mother in a rural area can take her infant to a reasonable healthcare facility would cost her the better part of an entire day. And that may be the difference between life and death for a patient with meningitis. I mean, the two biggest killers of bad infections that should be treated with antimicrobials in children are pneumonias and meningitis.
Yes.
And if you don't have access to antimicrobials within an hour, you have a dead baby on your hands.
Yes.
Okay, so this notion that we should have a blanket ban on access to antimicrobials everywhere is unlikely to
Yes.
work without us paying a very high price in terms of infant mortality. So what do you do? I mean, it's not very easy. So one has to have a strategy to address access to essential medications everywhere. At the same time, we need to put into place at the earliest opportunity a mechanism to modify, withdraw unnecessary antimicrobial usage. So this entire strategy of what we call antimicrobial stewardship cannot be simplistic or reductionist. It requires very highly skilled personnel who understand microbiology, who understand infectious disease, who understand epidemiology, but most importantly, understand how to help and support the other parts of the entire healthcare system so we optimize utilization of antimicrobials and also thereby help reduce the problem of multi-drug resistance, particularly in healthcare facilities.
Yes.
And one of the single most effective ways of doing this is to prevent infections in the first place. If you don't have an infection, you don't need an antimicrobial. And therefore, you're not going to have antimicrobial pressure giving rise to drug-resistant pathogens, right? So an effective infection prevention program in hospitals is imperative. What can you do at a community level? There are a lot of infections that can be prevented by an effective immunization program. Influenza, pneumococcus, Haemophilus influenzae, these are deadly pathogens, but they are vaccine preventable.
Yes. How has COVID-19 changed the whole lot of game about the immunization thing, sir? Like after COVID-19, only many people have got to understand what is immunization, what is the importance of it, because back in those days, none of us even knew about the adult vaccination. Many of the population doesn't even knew about the adult vaccination. So how has that changed in at least the little part of community?
I think what COVID did is it heightened everybody's understanding of the importance of prevention methodology, okay? Particularly, how do you get COVID? Bottom line is it's bad air. It's an airborne infection. You're exposed to a lot of air with a lot of virus in it, you are going to get infected, okay? Even with PPE and everything and masks and everything, remember, the risk reduction is 95%, not 100%. So a lot of people do get infected. And the principal reason why a lot of healthcare personnel got infected and died in India is a very poor air quality and the HVAC and air handling systems of most hospitals. They're horrible.
Yes.
Okay. If you have contaminated air and that's heavily contaminated, no amount of N95 masks are going to help you.
Yes.
Right? And then for the patients who got COVID infections, unfortunately, a lot of them, when they landed in a hospital with serious problems, are already severely immunocompromised because COVID causes a drastic reduction in CD4 cells and also NK cells, makes them very prone to infections of all kinds because both their adaptive immunity and their innate immunity is severely impaired. It's almost like having acute AIDS.
Yes.
And on top of it, COVID also precipitated a lot of metabolic disorders in a lot of people. For example, people who never had diabetes suddenly started getting hyperglycemic, and that further compounded the problem.
Yes.
Now, my problem was trying to persuade healthcare professionals to avoid using high-dose steroids that would further impair the immune system, and also to avoid unnecessary antibacterial agents that puts them at risk for fungal superinfections.
Yes.
Okay, and understand that, you know, that not everybody benefits from antiviral drugs with COVID. So
Yes.
COVID taught us, you know, the importance of understanding virology, understanding immunology, understanding epidemiology, but also understanding how important it is to pay attention to the basics of infection control and prevention.
Yes. Yes. So, when in the community, they have access. Like now that our pharmacies, there is no stop for any kind of dispensation of the antibiotics. We call them as Schedule H, but there is no inhibition from the government side or from the pharmacies. They don't restrict. They don't even ask for a prescription, for a valid prescription to dispense the antibiotics like amoxicillin, azithromycin, doxycycline. They're like widely used in the communities. How can we strategize to reduce this, sir?
I think that one of the things that we should think about is understanding the concept of empowering people to take ownership of their own health.
Yes.
Right?
Yes.
It was very interesting you bring that up, because just today, you know, I was consulting with a patient, and she told me a very interesting thing. She was being recommended a tracheostomy by her physician, and she had the guts to ask him why. All right. And when he could not give a satisfactory answer, she said, look, you're nuts. I'm not going to allow you to do a tracheostomy on me and make me a vegetable. So I think that's key.
Yes.
Empowerment of people through the right knowledge and information will go a long way in helping us reduce inappropriate interventions.
Yes.
Okay.
Yes.
Now, the problem is that most of us do not take the trouble to sit down with our patients and do all of that.
Yes.
It takes a very long time to do it. Okay. My typical patient encounters are something like anywhere from 20 minutes to 1.5 hours, depending on the complexity and the number of problems that I have to educate them about. Okay. The examination of the patients is very simple and easy. It takes only 5 minutes. So very often, the patients who come to me, they tell me, look, the previous doctor just examined me just like you did in 5 minutes, and that was it. There was no conversation.
Yeah.
Okay. You are the first doctor who's actually taking the trouble to sit down with me and explain to me what's going on, what my options are, how can I make choices. Okay. So every time, I will tell you, it's my personal experience that every time there is a major problem and I'm going hunting for the monster who caused the problem, I look in the mirror and I find the monster. So we need to do that a little bit more. We need to look in the mirror and ask, right, why did this happen? Let's take another example, an intervention that is notorious for increasing the colonization of the gut with multi-drug resistant pathogens. And these are all the proton pump inhibitors.
Yes. You keep
There
saying
is
that all the time.
absolutely no indication for a proton pump inhibitor to be automatically prescribed with antimicrobials. But 90% of the physicians in Hyderabad are doing that.
Yes, sir.
And I don't understand why. And they keep saying, well, it is to prevent, discomfort in the stomach. But the discomfort in the stomach is caused by alteration of the gut flora by the antibiotic. It is not caused by hyperacidity. So there is no reason to give an agent to reduce acidity in the stomach. This is a misconception. And when I explain this to patients, they are sort of flabbergasted. Really? I never knew that. Okay, and a lot of times patients are allowed to be convinced that they are the root cause of their stomach distress, which has many, many different reasons, is acidity. So they take medication to suppress the acid, and they actually feel better. And because, quite honestly, that's placebo effect. Okay?
Yes.
But the danger of using proton pump inhibitors is all proton pump inhibitors, by the way, are antibiotics. They do kill bacteria, and they do change the microbiome in the gut, which is a major, major host defense against drug-resistant pathogens.
Yes.
They also upregulate the genes for coding for resistance that make bacteria multi-drug resistant.
Yes.
And also, because they reduce acidity in the stomach, they reduce a major host defense against infection by foodborne pathogens like Salmonella, Listeria, Shigella, and so on and so forth. All right. Now, who is the culprit out here? We are. The healthcare system has allowed the pharmaceutical industry to push proton pump inhibitors to everybody, regardless of whether they actually need it or not. Now, clearly, there are specific individuals with specific conditions that do warrant using a proton pump inhibitor. It's perfectly reasonable to do that as long as you're doing it for that purpose. And then as soon as possible, you try to take them off of it.
Yes, definitely, sir. So these days, it is by default there in every prescription. And even patients have got used to sitting at home. If they feel little acidic or any kind of symptom, they just pop in that PPI. Even if we try to explain them, they don't understand the scenario of what it affects. So it is high time for us, like healthcare professionals, educate the common public and tell them that what it means taking just popping a pill doesn't, it might give relief for time being, but in long term, what happens, it is the responsibility is there on the healthcare professionals. Definitely, sir, as you've told.
I mean, I think that it is very hard for anybody to imagine that a pill, a proton pump inhibitor that they consider such a benign pill, not recognizing that it is also an antimicrobial, can potentially lead them to be colonized with an extended spectrum beta-lactamase producing E. coli or Klebsiella that might cause a urinary tract infection and pyelonephritis and bloodstream infection and kill them.
Yes. The long-term effect of it, nobody understands. That's
so also, I mean, the same is true of all of these modern infection control interventions that are becoming very problematic.
Yes.
Take, for example, the routine use of quaternary ammonium compounds, okay, as a substitute for cleansing with detergent. It doesn't work. Even if you want to use a quat, you first have to cleanse the entire paraphernalia with soap and water, dry it, and then apply the quaternary ammonium compound and let it sit there for several minutes for it to work. But by the time you have properly used soap water to clean the entire surface, there's nothing out there. There are no bacteria to kill. So using quaternary ammonium compounds makes no sense. And we are now seeing that those places that are using a lot of quaternary ammonium compounds as part of their infection control programs are actually seeing an increase in the number of drug-resistant organisms within the microbiome of the healthcare system. Okay, just like we humans have a microbiome, every healthcare patient care environment has its own microbiome. And that gets contaminated with all of these drug-resistant pathogens, in particular, the organisms that persist in the environment, like Acinetobacters, MRSA, or any Staph aureus for that matter, Enterococci, and a lot of fungi, particularly, now we have this multi-drug resistant Candida auris that's susceptible to nothing. So we need to go back to soap and water.
Yes, sir.
Soap and water as superior to anything else.
Anything. Yes.
Okay.
Definitely, sir.
Now let's take another practice, again, which should be abandoned, which is in the intensive care units, we started this notion of chlorhexidine mouthwashes. Well, it's a problem because there is no evidence to show that chlorhexidine mouthwashes are superior to regular toothbrushing and toothpaste in terms of prevention of hospital-acquired pneumonias. And excessive colistin exposure, chlorhexidine exposure, is a risk factor for acquiring colistin-resistant E. coli. So why are we using chlorhexidine all over the place? It's expensive, not warranted, and the more chlorhexidine you use, the more trouble you are going to get into.
Yes.
So targeted application and usage. Chlorhexidine is very good for preparing the skin for an invasive procedure, whether you're putting in a line or you're doing surgery. But apart from that, one should not use chlorhexidine routinely in every hand cleansing bottle of alcohol. It's not necessary. It's not required. It is not beneficial. In fact, it is harmful. But this is a hard sell because I am competing with the pharma industry and the device manufacturers and their powerful marketing tools. And believe me, they are better at it than I am in terms of persuading a healthcare professional what is backed by scientific evidence and what is a fad.
Yes. It is going on everywhere. The many of the healthcare professionals also doesn't know probably that chlorhexidine will have so much of impact. And if we see, probably the healthcare professionals also have started using chlorhexidine gargles just for a fancy thing. So that
Very
has been going.
dangerous. I tell them, look, dear healthcare professional, one of the most tragic things that can happen is you pick up one of these bugs from the hospital because your hand hygiene is not good enough. And then you're using all of these pots and chlorhexidines and everything else. So you have now acquired a very, very, very virulent drug-resistant pathogen that you are taking home and giving to a loved one at home who succumbs to that infection. Talk about the most tragic thing that can happen to any health professional. They are now responsible for causing severe morbidity and, God forbid, even mortality of their own loved ones at home.
Yes. Totally agree with you. So totally agree. So to explain all of this antimicrobial resistance, or be it the stewardship programs, to deliver it to the community, now that we are in the digital era, so what kind of digital tools or mobile apps or telemedicine platforms that could serve us to deliver this kind of communications to the general public, sir?
You know what? I think that one has to understand the science of persuasion. Okay. And it is very clear that anybody is far more likely to accept an assertion as a fact when it comes from somebody they trust. Now, the same fact, the same assertion coming from somebody that they don't know, they're going to be very skeptical and may not, in fact, may actually resist being persuaded. Okay. Particularly if they have already made up their mind that this is what is the right thing to do and this is what is the wrong thing to do. So I think that this is a problem that has no easy solutions, and there's a lot of hard work ahead of us. I think that, once again, I would say that we are better off investing in prevention of infections that automatically reduces the craving for, and I call it a craving, for these interventions that they are being assisted into by healthcare professionals who are addicted, and please underline the word addicted, to prescribing the wrong interventions, okay? The wrong antimicrobials, excessive duration of antimicrobials, and other agents like proton pump inhibitors. Even in the hospital, I try to tell them, look, don't use beta-lactam with beta-lactamase inhibitors. They are notorious for disturbing the gut flora, 99% of which is anaerobic. And the beta-lactamase inhibitors, along with the beta-lactam, disturb the anaerobes. If you don't need to kill the anaerobes, why are you using a drug that is targeted against anaerobes?
Yes.
Use a narrower spectrum agent that does not disturb the anaerobic flora, all right?
Yes.
Or does not disturb it to the same extent. All right. So this is something that, and again, what people don't understand is a beta-lactamase inhibitor will in no way potentiate an inherently weak beta-lactam that does not have significantly potent activity against pathogens. So I think the key issue is that people need to understand what is the difference between potency and spectrum. They often confuse potency and spectrum. They think that all broad spectrum agents are more potent. Not true. That, when you're looking at a specific pathogen, you also have to think about what antimicrobial agent would be the preferred agent in terms of potency and efficacy. And if you can use a narrowly targeted agent that preferentially goes after that pathogen without disturbing the rest of the flora, that would be the most advantageous thing to do.
Yes.
So this is a constant battle because the clinicians always want to use gorillamycin that has a wide spectrum, but not necessarily as potent. Okay, a good case in point are all of the tetracycline and tetracycline derivatives. They're broad in spectrum, but their potency is not great, and therefore they disturb the gut flora even more, and the potential for getting colonized with drug-resistant pathogens and eventually getting infections with drug-resistant pathogens actually goes up. So this is a very important thing for people to understand. So what I'm hoping for is that in the not too distant future, we will have AI tools that are being used by everybody before they make a decision about either diagnostic intervention or therapeutic intervention. Okay. And the reason I say that it should be done soon is you don't have to wait for all of those tools to become available. They are already available. Okay. I use my smartphone to pull up recommendations for anything and everything. I mean, it's as simple as going to Google.
Yes.
And Google uses AI to pull up the relevant information that a healthcare professional can use to help them make better decisions. So why isn't everybody using AI? The future is that some health administrator, will get fed up and say, I can't reform these healthcare professionals. I'm just going to put in an AI program that will automatically evaluate the patient, decide what intervention is required, and then go and get that accomplished. And that way, I have a greater assurance that the patient will get a more appropriate intervention than relying on healthcare professionals. All right.
Definitely. Even for the
So a
general
lot of
public
people are
as well.
still already doing it automatically. Okay.
Yes.
So
They are
their
able to.
decision support systems, for example, at the University of Illinois, where I worked for many years, when I put in an order through the computer for an antimicrobial, first of all, it'll ask me the indication. And if I have put in something that's not quite right, it'll automatically flag and say, hey, doc, this is not the best option. Number one. Number two, it'll automatically check for undesirable drug interactions with other medications that the patient's already on and say, look, you need to address this. And yet again, there is another level of protection, because if I have overridden all of these computerized prompts and everything else and insist on doing something that is not desirable, I'll get a call from the pharmacy by a doctor of pharmacy who's head of antimicrobial stewardship and say, Dr. Yeldandi, can you please explain to me why you're insisting on doing this? Okay. And by the way, my practice is periodically reviewed by my peers, other infectious disease specialists, to see whether or not my practice of medicine conforms to the best standards of care. So there are multiple checks and balances that force healthcare professionals to keep on improving their practice. Okay, and tomorrow, all of these systems will be driven by AI, because it's very expensive to have actual humans doing all of this work. And they don't do it as well as an AI program does.
Yes, definitely not.
All right.
Oh, well, so we have come to an end of the session, sir. I would like to ask you, what is your suggestion to the young healthcare professionals and students out there who is interested to promote AMSP into the communities? How can they communicate, or how can they go out and say?
Yeah. So I think this is my advice to every healthcare professionals. All right. So I said, firstly, remember that this is what, is said in The Doctor's Dilemma. George Bernard Shaw's character says that every profession is a conspiracy against the laity, okay, which is what all professionals do, and particularly healthcare professionals. They use all this very confusing jargon that confuses themselves, confuses their colleagues, but confuses the patient more than anybody else and anything else, right? So avoid that. And like the famous physicist Feynman said, okay, if you can explain everything in simple English that anybody can understand, you have correctly solved the problem. So all young health professionals, please learn that even today, and certainly by the time they come out of training, there'll be two classes of people. One class of people who are always doing the right thing and have learned how to use AI tools properly. And the other class is unemployable. So you will become extinct.
Yes.
Okay, because more and more, I mean, look, 30 years ago when I was treating people with cystic fibrosis and evaluating them for lung transplant, they would come to me with a stack of literature that they had pulled from the internet and say, hey, doctor, please explain to me what all of this means, and what's your perspective on so-and-so scientific article about so-and-so and so. And I had to be able to help them with that, which meant that before they even came to me, I had to understand that body of literature and the evidence and be prepared to give proper guidance to somebody that was authentic, authoritative, and true. So tomorrow, you will not have the ability for any healthcare professional to simply confuse patients or anybody else using lots of jargon and hoodwink them. I'm sorry I'm using such a strong term, but that's the reality.
Yes.
And people had better wake up.
as you've rightly mentioned, sir, everybody should take ownership of their health and then start coming up, asking questions why, like not just follow what the consultant says or the doctor says, just asking why and understanding about their own condition. There probably we could get a lot of difference into the communities as well, I guess.
Absolutely. The more people know, the better off they are.
Yes, sir.
Right.
Yes,
And
definitely.
in this day and age, it is so easy to hook them up to
Mhm.
credible sources of information through the
Yes.
internet. All right.
Mhm.
Many major academic medical centers have a lot of information which is for designed in very simple language, easy for people to understand, lay people to understand. The CDC has it, the WHO has it, Mayo Clinic has it, all right, Cleveland Clinics has it. A lot of people do.
Yes. We are end of the conversation for today's episode, sir. Thank you so much for joining us. And we had such an interesting conversation. And always talking to you gives me a different perspective altogether. I always learn new things whenever I have conversation with you, sir. It's a pleasure talking to you, sir. Like every time.
Thank you.
so
Thank you
much.
very much for the opportunity, and it's been a pleasure.
Thank you so much, sir. Thank you so
Thank
much
you.
for joining.